let me turn the conversation about this study and the use of this drug to some practical issues. One of them is the testing. There's a companion diagnostic testing for the FLT3, ITD, and TKD. I've had situations where the PCR testing, which is how the companion testing is done, is clearly positive. Remember, it has to be over a 5% allelic frequency to be considered positive, and those are the patients who went on the study. But then you get back the next-gen sequencing panel back 2 to 3 weeks later, and it's negative. And when I really push the pathologist, they say, well, maybe it's there at a low level, but we just can't see it.
Yeah.
Can you explain that to me? And what should we do?
Yeah, so next-gen sequencing for FLT3 ITD is challenging at a technical level. One of the reasons is what happens with the ITD is there's insertions of sequence into the FLT3 gene right in a region that on the protein is basically functioning as a negative regulator. So if you insert sequence there, you lose that function and the kinase stays active. But how much sequence is added is variable. You could add 3 base pairs, 30 base pairs, 150 base pairs, 400 base pairs. And if you add a large sequence into that area, it's actually large enough so that when they look at the sequence, it doesn't align to anything in the genome. And they don't see that that is something that should be considered a mutation. They just don't know where to put it. It looks like FLT3, but they don't see that it came from the prior sequence, and it doesn't get counted as an abnormality.
Because what sequence has to be exactly where the two things are joined
so that
together,
gets discarded,
right?
That gets thrown out, and they don't see that that's there. So that can be a problem. That's one reason that this can be an issue. The other is that the sequence is longer, and so the speed with which the sequencing reaction goes on takes longer in that sequence, and then it doesn't catch up, so the allele frequency drops below the reporting threshold, especially at 5%. So if you have a small amount of the mutation, it might not be picked up by this unless they have special algorithms to look for FLT3 ITD.
So practical lesson here, a PCR-based assay should be done for FLT3 at the time of diagnosis. One, because the next-gen sequencing panel may miss it, and two, there's a difference in time, right? You can get the FLT3 PCR back.
They're getting better with the next-gen sequencing, so they're really getting better at matching that to the PCR and having concordance, and they're really pretty close now. It used to be much worse, but you're still missing cases with it. But I agree, the timing is the really critical thing because of what Eunice said, which is on the study, we know the benefit happens when you give it for 2 weeks starting on day 8. And you don't want to get the results back on day 20 and oops, we're so far out, we don't know if there's a benefit.
Yeah, we don't know whether it still would have the benefit of it.
Eunice, direct question. Do we really know that this is targeting FLT3 or could it have other activity?
And I think that's an excellent question. That has been something that, now that we have the success of this agent, how much of it is due to the FLT3? Because when you actually look at the kinome map, like the array of kinases that is targeted by midostaurin, it's pretty impressive. It hits a lot of different things, and that might be in part why we get the GI toxicity, diarrhea, nausea, vomiting. Some patients develop rash, which is significant, over long-term maintenance. The drug interacts with a lot of other drugs. So one of the issues we've had practically is that it can cause QTc prolongation. It interacts with azoles. So there's many things about it, and part of that maybe it's such a broad spectrum what we call pan kinase inhibitor. So that, I think, has led to people to say, well, ideally, AML is unlike CML, which I mentioned previously. CML is driven by BCR-ABL. That's the main pathogenic mechanism driving the proliferation of CML cells. That FLT3 does drive AML cells and makes them hyperproliferative, but it certainly is not what we call a founder mutation, as you were talking about with that initial molecular profiling data. It's a secondary mutation. So there are many other signaling pathways which can drive AML, FGF, VHF, RAS, other things. And so I think potentially in the upfront setting where we're trying to kill as many leukemia cells as possible, having a broad spectrum agent, chemotherapy, anthracyclines, cytarabine, a pan kinase inhibitor might be really useful. But the question right now is if we make a more potent, specifically targeted, selective FLT3 kinase inhibitor, how does that function? I think we're going to discuss that a little bit later.
I think that's clearly where the field is moving. We want to see, and for good reason, because when we've looked at midostaurin as a single agent in relapsed refractory patients with FLT3 mutations, the clinical activity is pretty modest. It clears their blasts, but it doesn't really do very much for their bone marrow.
Not durable response.
And it's not very durable. It lasts a very short period of time. The newer drugs have much more significant and much more consistent reductions or elimination of circulating blasts. They clear out the marrow. And their responses can be more durable.
And they can be potent, very potent. As
And
a
those
single
drugs can
Right.
be added to frontline therapy.
Okay, we're
We'll
going to get to that, right? We're going to get to that. So before we finish this up, a couple of very practical issues. You mentioned the drug interactions, midostaurin metabolized by CYP3A4, our antifungals, our CYP3A4 inhibitors. There's a concern for more toxicity. At this Congress, there is a poster being presented showing that in patients who were receiving azole antifungals, there did not appear to be extra toxicity that was seen. Still, I think it's prudent to be cautious, but you don't have to dose reduce. Has that been your
Right.
experience?
Yeah.
And just carefully following the EKGs sometimes is enough,
Yes.
I think.
Yep.
So.
And if you're running into excess GI toxicity, if the patient's getting prophylaxis, certainly an alternate drug is reasonable in that setting, whether it's an echinocandin or an alternate agent.
Practical issue. Maintenance or no maintenance. The study was not designed. They were not re-randomized. Okay, so it's not in the label. It's not in the
US label.
U.S. label. It is in the European label. So, yes or no? Do we give midostaurin maintenance or
Dick
not?
Larson presented an abstract just yesterday looking at the impact of the maintenance portion. Now, again, it was not a re-randomization, and they did all the statistically modeling and so forth to look at how the patients that went on to maintenance did if they had received both placebo and midostaurin. And by their predictive modeling, there was no significant difference in terms of relapse or overall survival or selection or enrichment of improvement outcome in the patients that received the midostaurin maintenance.
Okay, I'm going to push back a little bit, okay? Because there was a curve there that really gave me great pause as a clinician.
It did.
And that, you know what I'm going to say, right? It was when they stopped the midostaurin and placebo, in the midostaurin arm, there was this very rapid drop or number of recurrences. And it was temporally related to stopping. And we don't know how to identify those patients. So I have heard people say, not only am I going to give maintenance, maybe I need to continue the maintenance because I don't know how to
I
identify
understand,
those.
But the statistical analysis of that data would support the FDA's decision.
Yeah, there's
not to
statistics.
give.
There's statistics.
Well,
but then you have the
hasn't-
patient. You stop the midostaurin, and a month later they come
Okay.
back with relapse, and they say,
But-
Dr. Erba, what did
What
you
did you
do?
do?
But Dr. Erba, are you going to pay for that drug for that patient?
I'm sorry, I don't pay for anything.
Because who's going to pay for that?
Good points. I think we better
Right?
move
Well,
on.
Jorge, what did you want?
Just another practical question. This is, ITD. What about DA35? Because we do have a small subset of patients, and what they have is DA35. So do we use midostaurin or not?
Well, they were in
And
the
that's
study.
important
They were
because
in
we
the
don't
study.
always move patients with a DA35 to a transplant because it has not been
Correct.
established
But they
to have
did
as
better as
sinister
well.
an
They
effect.
both ITD and TKD, independent of the initial allelic ratio, and they stratified for high or low allelic ratio. Both did
Well,
fine.
and I bring it up because it's important. Not all the FLT3 inhibitors
That is a
inhibits,
distinguishing point,
correct. And
yes.
sorafenib, which we've been using it forever because it's not approved for this indication, but it's been available. That's the one we've used until we have midostaurin. That doesn't affect the DA35, so we wouldn't expect that to be the case, for example.